Mrs. S is a 46-year-old premenopausal woman who formerly worked as a reporter for a local newspaper and now works as a realtor. A married mother of 3 children, she exercises 3 times a week and denies use of both tobacco and alcohol. About 6 weeks ago, she noticed a small lump on the outside of her right breast. Mrs. S typically develops some cystic lumps in her breast about 10 days before her period, but this one felt different. Looking at her family history, her paternal grandmother had been diagnosed with breast cancer before menopause at age 45, and her mother had also been diagnosed at the same age, later dying from breast cancer at 73. Concerned by this, Mrs. S scheduled a physical examination with her doctor. A bilateral mammogram later showed several indications that breast cancer was indeed present. 4 masses between 1 and 1.5 centimeters were scattered through her left breast, and 3 half to 1 centimeter masses were in the right. The larger lump she originally felt was irregularly shaped, with a diameter of up to 3.2 centimeters in some regions. Skin thickening and enlargement of the axillary lymph node was observed, and 6 Y-shaped microcalcifications extended toward her nipple. Evidence that the irregular mass was extending into her pectoral muscle was also observed. An ultrasound and biopsy confirmed evidence of infiltrating breast carcinoma. The tumor sample exhibited tubules in 80 to 90% of its size with abnormal vascularity. The sample was also observed to have 3 to 5 cell divisions under a high-power microscope and tested positive for estrogen and progesterone receptors. In total, this information indicates that Mrs. S's breast cancer has progressed to grade 2 and stage 2B. Mrs. S met with a breast surgeon and radiation oncologist to discuss treatments and was provided with 2 options to address her breast cancer. They could either perform a lumpectomy with sentinel node biopsy followed up with breast irradiation, or a modified radical mastectomy with sentinel node biopsy with or without reconstruction surgery. Mrs. S chose breast conservation with radiation and was placed on tamoxifen therapy. She followed up every 3 to 4 months for 2 years, every 6 months for the next 3 years, and annually thereafter. For the first 6.5 years, all checkups were negative for breast cancer. However, after 80 months of radiation treatment, Mrs. S returned to the clinic due to bone pain in her lumbar region and left hip, and a severe headache that could not be alleviated with over-the-counter medications. A bone scan revealed lesions in the lumbar spine, not caused by impending fracture or spine compression, while a chest x-ray observed 3 small lumps on the upper lobe of her left lung. Lastly, an MRI showed a small mass in her right frontal lobe, all indicating the spread of her breast cancer into other symptoms of her body, now categorized as stage 4 breast cancer. Mrs. S's serum therapy was increased at least twice the usual amount for several concentrations in hopes of fending off the spreading cancer.